We are live.
Can you mute everyone?
So,
We are live,
welcome,
please.
welcome everyone again to yet another module of this very exciting program, Phaco emulsification in difficult situations, and OPMS. That means one problem, multiple solutions. This is a video assisted certificated course which all our AIOS members and in fact ophthalmologists can take. And important thing is that this is running in 9 modules, and you will be given a certificate after you finish the course. At the end of the course, there are 15 questions which have to be answered. And I would particularly like to thank Dr. Harshul Tak, who's the program director for this course, who's taken this forward. And I'm sure again you're going to have a very uh, exciting session today. So over to you, Harshul, for the proceedings.
Yeah. Thank you so much, Namrata ma'am, for giving this wonderful opportunity and to entire AI scientific committee. So, as ma'am said, this is the eighth module, and this is on very important module on phaco in post-refractive surgery and abnormal corneas. So we have today speakers Dr. Vardhaman Kakaria, who is from Pune. We have Dr. Anaga Harur from Mumbai. We have Dr. Himanshu Matalia from Bangalore, Dr. Rushad Shroff from New Delhi. So they'll be taking us through various aspects of these kind of cases. Thanks to moderators Dr. Aishwarya Anuj, who is a prolific cataract and refractive surgeon from Narayan Netralaya, Bangalore, and Dr. Rohan Mehra, who is a wonderful young cataract surgeon from Uttarakhand. Thank you so much for taking care of this program. And thanks to our expert panel, Dr. Arvind Moria, who we all know is a great teacher and innovator. Thank you so much. Dr. Krishna Prasad Kudlu will be joining soon. And I'm really excited to have Dr. Steve Sipser with me from USA. So he had come for RSI meeting, and it's great to have him here in Jaipur. And
Excellent.
so, yeah, so hand over to Dr. Aishwarya now and Dr. Rohan.
Thank you, sir. So today it's a privilege for me to introduce Dr. Vardhaman Kankaria, sir. He is the founder director of Asian Eye Institute in Pune, which is a tertiary care center known for cutting-edge eye treatments. He is also India's first dual fellow, as the India's first surgeon to complete dual international fellowships in advanced refractive surgery from the University of Crete, Greece, and Bascom Palmer Eye Institute, USA. He is specialized in cataract cornea refractive surgeries, and he is also a LIMCA record holder for the world record for his expertise in LASIK surgery and is a pioneer in robotic bladeless laser cataract surgery. He is also an award-winning doctor who has not only won numerous prestigious accolades, but also the AIOS Hardia Award for Refractive Surgery. So I welcome Dr. Vardhaman sir for his talk today. And his talk today includes biometry challenges in post-refractive surgery eyes. Over to you, sir.
Thank you. Thank you very much, Dr. Aishwarya, for that kind introduction. And thank you to Dr. Harshul for the kind invite. And thank you to Dr. Namrata ma'am for giving everyone this opportunity to learn. And I'm going to talk to you about especially biometry aspect after the previous corneal refractive surgery. Friends, we all know that corneal refractive surgery has actually come a very long way. The first real documentation of corneal refractive surgery was almost a century back when Professor Sato in Japan performed what was in those times called as a posterior arc. And from those times, we have had a lot of evolution. And now in the current generation in 2026, that when we have access to the latest generation of technologies like Smile, Contura, Weblight Plus. But I think if there was one procedure which truly changed the aspect or the acceptance of refractive surgery globally was this LASIK procedure. So as we know from the time the first LASIK was performed, Now there are more than 4 or 5 million people who have undergone a corneal refractive surgery in the last 3 decades plus. And those patients who were those in those times called as the baby boomer generation, these are the same people who are coming back to us now, because now after 30 odd years or 20 odd years, when they had laser vision correction as young patients, now they are in the age where they develop cataracts, and they are now coming back for cataract surgeries. But these post LASIK surgery cataract patients have abnormally high expectations. They also have a relative intolerance for diminution of vision. They request early cataract surgeries. They are very demanding because they have seen the success of the previous eye surgery on their eye, which happened to be LASIK, but now they expect the same kind of precision with even their cataract procedure. But the irony is that in the patients who very much desire the most accurate postoperative refractive corrections, unfortunately, the IL power calculations are least predictable. And there are a variety of reasons for that. And before we actually understand why this happens and what are the solutions, let's first understand how the formulas work in the virgin eyes. We all know that when the formula generally can be categorized into regression formula, which develops or which depends on the accumulated data, and the theoretical formula, which depends on what is called as the principle of ELP, which is the effective lens position. The effective lens position is distance between your anterior refractive surface of the cornea and the nodal point of your crystalline lens, or the IOL that you will be implanting. So in the beginning, the ELP was actually understood to be static at 4 millimeters, but then of course we very quickly understood that the ELP will be shorter for hyperopic eyes and much longer for the myopic eyes, and it has to be also modified. When it comes to the prediction of ELP, variety of these formulas depend on different parameters, ocular parameters, to come to the best ELP prediction. But you can very well see that vast majority of this formula depend on keratometry. Now let's understand the second part, which is how and why the IL power calculations are more difficult and different after examined laser corneal laser procedures. And that's because there are three different sources of errors, just to simplify things. The first one is the index of refractive error. The second one is the error in the measurement because of the instrument. And third one is the formula error, which tries to predict your ELP. So when it comes to the keratometry reading error, or the index of refraction error, we all know that when we look at the refractive index of the cornea, we rely on this formula, which actually understands or presumes the anterior versus the posterior curvature of the cornea to be in the ratio of 1.21. But that does get modified, of course, after the corneal refractive surgery. For example, if somebody who has undergone a myopic LASIK procedure, the keratometry is going to be overestimated because of this reason, and this overestimation of keratometry leads to underestimation of the IL power calculations. As against that, anyone who has had a previous hyperopic ablation, there is an underestimation of keratometry leading to surprises in patients who have undergone hyperopic treatment in the past as well. The second error is the instrument error, or which can be called as the topography measurement error. We all know that all the current generation of keratometers and Placido devices do not calculate the keratometry at the apex of the cone, which should be the most important thing. But instead of that, they actually calculate it at about 3.2 millimeters apart, and that leads to errors in the calculation of keratometry. And the third is actually the formula error, because we all know that when it comes to calculations or prediction of the ELP, all these formulas in the virgin eyes, they depend, as you can see very well, on keratometry. And because there is a overestimation of keratometry in patients who have undergone myopic LASIK in the past, there is going to be underestimation of ELP, leading to uh, basically underestimation of your IOL power, thus leading to hyperopic surprises. And exactly the opposite thing happens in patients who have undergone hyperopic treatment. There is underestimation of keratometry, leading to overestimation of ELP, and thus leading to overestimation of the IL power, thus leading to myopic surprises. So once we understand why this happens, now is there a way around it? How do we calculate the IL power? One of the easier ways to do that is using a keratometry independent formula, such as Haigis. So Haigis does not depend on keratometry to give you ELP prediction. So that is one of the easiest thing that one can do. But there can be other things which can be worked out. These are called as the Aramberi double K method. The Arambari double K method depends on the pre-operative keratometry reading determination. This particular reading is used for ELP prediction, and the true post-operative keratometry measurement, which can be used for calculation of the IOL power. So once we have all these things at our disposal, how do we calculate using these different formulas? So basically, as you can see here, when you have history which is available or the history which is not available, there are variety of formulas which can be used, but how to go and calculate in particular each and every formula, that is going to be a very tedious process. So very fortunately, in ESCRS website, on ESCRS website, we have the ASCRS online calculator, which actually is very intuitive, and it actually lets any novice also to predict the ILO power decently well, in which you are supposed to feed in first which type of refractive surgery was done in the past. Second one is what kind of lenses are you using, of course all the current data that you have about this patient. And then when you have all these things together, then you actually have a window in which it shows you variety of formulas clubbed together. It gives you basically a minimum and the maximum calculations and also the average. So basically it is always better to err on the side of more than average in these cases. There are variety of studies which have looked at different formulas, and they have seen that the current true K no history method or the OCT based analysis has been one of the best formulas, such as the Barrett's true K, and this has been now incorporated also in the ASCRS formulas. This was one of the things that we had noted also even 15 years back during my fellowship at Bascom Palmer, that post RK patients were doing very radically when it came to the IL power calculation. And the current generation of even literature, if we're looking at them, even with a span of 1.5 diopters of the prediction value, only 65% of the cases would land in that. And one of the main reason is there is also going to be a lot of instability because of variety of different zones, variety of different thicknesses, sometimes microperforation, scarring, going from very center of the optical zone till the limbus. So every RK case is very individualistic. So let us look at this patient who had undergone RK in some other center and actually showed to us almost 25-30 years later uh, uh, for her cataract surgery. So you can see that this RK marks were actually going right from almost very close to the visual axis to the peripheral limbus, and there was a lot of scarring. Because of that, there was extreme amount of flattening which was seen, and this had gone to even 27 to 28 diopters. When we came to the IL power calculations on the IL master, you can see that it actually showed a IL power which was varying a lot, right from 13 diopter to almost 17 diopters. I'm not going to get you through the details of the procedure because I believe Dr. Anaga is going to speak to you on it a lot. Um, but one of the things which have helped me in this erratic solutions situations is to do what is called as the intraoperative retinoscopy value. So intraoperative retinoscopy and using a Maloney's method of multiplication of 1.7 or 1.8 gave about 17 diopters in this case, where the other formulas were actually showing 13 or 14 diopters. And with this, we implanted this lens with the calculation method or multiplication method, and we could come to very reasonable amount within one diopter in this particular patient, in spite of having a lot of incisions and a lot of scarring in this patient. So with this intraoperative calculations of retinoscopy, we have seen so far in our series of 38 patients that 90% plus patients were within plus minus one diopter. What happens to the patients who have undergone intacs? Basically, you just go to the AFCRS formula and go for myopic LASIK calculations using Barrett's true K and go for the said values. And the most important thing that we have to know, because there is a lot of increase in the phakic lens implants all over the world now. If somebody has undergone a phakic lens implantation, there is practically no change that you should be doing in your IL power calculations as such. I think this is not in the purview of my talk right now, but IL selection itself is also very important depending on what procedure has been done in the past. For example, somebody who has undergone hyperopic LASIK, it is better to go for non-aspheric IOL. Somebody who has undergone a myopic LASIK, it is best to stick to the IOLs with a negative asphericity. And eyes with very complex aberrations, it is better if you have access to zero aberration IOLs. And patients who have significant astigmatism, if they are regular, you can still go ahead and implant a toric monofocal lens in them as well. So thank you so much again for this opportunity to Dr. Namrata ma'am and Dr. Harshul. Yeah, thank you very much. Thank you.
Thank you, sir. Sir, I wanted to ask you a question that do you still keep that target refraction of post-RK cases like according to the cuts on the
No,
cornea?
not really, not really. I think that was more
Not
in the
really.
past when it was slightly more crude method. But I think right now with the current ASCRS formula in patients who have undergone less than 8 incisions works well. And anyone who has 12 and beyond, I think I've seen the technique that we are using is doing much better. Yeah, because if you go to only by the cuts, every cut is different, and every cut will lead to different amount of corneal irregularities. So yeah.
Yeah. Of course, they have mixed cuts also. It's not just
Many
the
times. Yeah.
concentrate cuts. They always have those
They
extra
also have
cuts which are made
sometimes
sometimes in
some
skin.
astigmatic keratotomies also being done between those arc
Yes.
incisions also. Yes,
Yeah.
yes, true, true.
The estimation, sir,
Dr.
of
Rohan?
yeah. The estimation of the hyperopic shift, sir, like how do you take that into consideration when you're choosing your
Post
IOL?
RK. For the post RK, you're saying?
Yes.
Yeah, so basically, I think in post RK, I always try to err on the side of myopic, right? So basically, for other patients, if we were going, like for example, like post LASIK with ASCRS formula, and if you consider between average to the maximum value that you have, but in RK, I would always err on the side of having the highest calculated value. On probably go even beyond that, depending on the clinical feel of it. For example, in some patients, as we have seen, if I see that there are cuts are longer and they look as if that there will be, because one of the reasons to have a hyperopic shift is that there is going to be mild gaping of those incisions, and that leads to unstable cornea in the beginning for about 2-3 months and a mild hyperopic shift which settles down. But if you go on the side of slightly more myopic calculations from before, or on the side of 0.75 myopia
Okay.
instead of, yeah, so
So
it
in
has.
that ASCRS calculator, so basically whatever power it is showing on max, you would go with that.
Rohan, we have
RK,
a
RK,
talk
yes.
on that. We have a
Yeah,
lot of examples in that.
right. Sure.
Maybe we can have a
Mm,
discussion after we see that,
sure. Fine.
because then there
One
will be a
last question
repetition on
to
that.
Dr. Vardhaman, sir. So,
Yeah.
which biometer are you using regularly for these post-refractive cases?
Yeah.
Or do you
So I'm
have
using,
to?
yeah, we have currently two IL biometers. One is the IL Master 700 and the second one is the Tommy. So we
Okay.
have two of them. Yeah.
Thank you, sir. So, I
Thank
think
you.
now
Thank
we
you very much.
can go to Dr. Anagha, ma'am. Dr. Rohan, please.
Yeah. So it is my pleasure now to introduce Dr. Anaga Harooj. She's a renowned ophthalmic surgeon, consulting ophthalmic surgeon and medical director of Anil Eye Hospital, which has several branches across Dombivli, Kalyan and Thane regions of Mumbai. She is a gold medalist from the University of Mumbai. She secured the first rank in her MBBS and was the topper in all subsequent postgraduate examinations, which included the MS, the FCPS and the DNB. She specializes in advanced cataract, cornea, glaucoma, and LASIK surgeries, having performed refractive procedures for over a decade now. So she's extremely experienced to be dealing with this topic. She serves as the honorary secretary of the Maharashtra Ophthalmic Society and is an active member of various national bodies like the AIOS and IRSI. For awarded professionals, her contributions have been recognized with prestigious honors, including the Bhishyagarva Award for the Best Doctor and Best Surgical Skills Award from the Women's Ophthalmic Society. So, ma'am is going to be talking to us on optimizing outcomes in post-RK cataract surgery. Over to you, ma'am.
Yeah, thank you so much, Rohan. Thank you so much, Dr. Namrata ma'am and Harshul, for this opportunity. So, I'll be speaking on a patient who has come to you post RK surgery. Like we've already seen, these patients have already undergone a particular kind of refractive surgery, and now the challenge is how to give them the best possible visual outcomes. So, we need to remember that there's a very high chance of a refractive surprise in these patients, and which IOL to use, which IOL formula to use is basically going to be the important decision. So the challenges are an inaccurate IOL power determination, which leads to an unexpected refractive surprise. Issue of visual quality also, because it's not just the quantity of refractive error, but the quality of the vision that we are going to give. Higher order aberrations, especially increase in the amount of coma or quadrifoil or tetrafoil, and the issues of dry eyes also. So we also need to be very wary of using premium IOLs in these patients. Now, getting a proper keratometry in all these patients can be very tricky. We have a choice of which keratometer to use, and remember, not all of these K readings are created equal. Like if you take the manual K, that will give you at a 3.2 millimeter ring, whereas the IOL master will have a different area. The lens star will give you at a different diameter. The topography will give you a SIM-K at a different diameter. The pentacam at EKR will give you at a different. So the closer you go to the center, it's more accurate. So what actually is the fallacy of the keratometer is you're overestimating the keratometric reading from the paracentral area, ignoring the flatter central region, underestimating the IOL power required, which causes the hyperopic outcome. Now the difference between LASIK and RK is in RK, you flatten both the anterior and posterior curvature because of the 90% deep cuts. Whereas in LASIK, you have only the anterior curvature that is flattened, and there it is the back to front ratio which is changed. Whereas in RK, because of the very deep cuts, you end up having a very small central optical zone. So we already saw how there are changes in the flat K, which assumes a falsely shallow post-op ELP, which in turn recommends a lesser IOL power, and 1 millimeter error in ELP corresponds to a 1.5 diopter change in the final refraction. So in our case specifically, there is a very unique problem that over the day there could be diurnal fluctuation, which means in the morning the cornea may be a slightly swollen, so be more hyperopic, and over the course of the day it might undergo even a 1 diopter myopic shift. So ideally in these patients, we make it a point to repeat these readings and look for reproducible or consistent readings. And we know that there could be post-op transient hyperopia due to stromal edema at the incisions, which increases the central corneal flattening. So now here, like we were discussing earlier, it was basically recommended that increase in the number of incisions, ideally you need to target a little more of myopia. Okay. Now, because we also know that it's not just a short-term hyperopic change, but also a long-term hyperopic drift. So people have studied and found that targeting almost say minus 1.5 in by Chen et al. Reduce the frequency of post-cataract hyperopia. So basically you need to target myopia in these patients. Remember not to cut the RK marks when you're making the main incision as much as possible. Now, regarding use of premium IOLs, now toric IOLs, we have used a lot of toric IOLs in these patients, but only after considering what is the kind of astigmatism, whether it is regular, irregular, how much are the higher order aberrations, whether it is stable or not, and counseling the patient well. Whereas the use of multifocals is definitely we're going to be very, very difficult because of already reduced contrast sensitivity, higher order aberrations, and the very high risk of night vision issues, along with obviously a risk of residual refractive error. Counseling in these patients is very important. They also need to be told about not just about higher order aberrations or quality of vision, but also a possible need of correction in the future, probably with an IOL exchange or a piggyback, and also night vision issues. So let's see a few cases. Now, this was a 56-year-old patient who came with us with an 8 incision RK. So if you look at the cylinder here, it was almost 1.62 and 2. So would you use a toric IOL in this patient? Now, this was a topography of the patient, and you can see here spherical aberration is almost 1.2, which is quite high. So the patient has been counseled well. Now this is the ASCRS online calculator. So just as we were discussing now, Dr. Rohan, we were talking. So it gives us 3 readings. One is average power, the minimum power, and the maximum power. So if you see here 16.79 and 17.3. So because it was an 8 incision RK, we used a 17.5. And we also compared it with the Barrett-Truque formulas. Now also here in the ASCRS online calculator, you can put in the Zeiss Atlas values from the 1, 2, 3 and 4 millimeter ring values here. So the more data you put in, it gives you more and more accurate. So these ASCRS online calculator has multiple formulae already incorporated into it. Another important factor that you need to see is the EKR report. Now here, what do you mean by this? So if the base is very, very large, which means that there is a greater keratometric variability vis-a-vis a very tall peak where you find that the keratometric variability is less, which is a better prognosis. Now, this was the patient where we took up for a toric IOL. Now, how differently would you do a patient with RK? So first of all, when you are actually making the incisions, as far as possible, try to avoid taking an incision in the area of the RK incision. Now here, unfortunately, it was a toric and we had to take it there. Another thing that you need to do is keep the bottle height a little low flow parameters, and be very gentle because they are very deep cuts and sometimes they can open up when you are trying to do a lot of maneuvers. So you need to be very careful. Otherwise, by and large, the say steps of surgery are almost the same and you align the lens. Now look at what happened in the post-operative period. Second day post-op, patient ended up with plus 2.5 in both the eyes. But over the period of 4 weeks, you can see how the hyperopia reduced. So do not be in a hurry or rush. Give them a little time, and usually by 3 to 4 weeks, this hyperopic shift usually reduces. If at all you need to do some kind of procedure or an IOL exchange or piggyback, ideally you should not take this decision until at least 2 months have passed and two consecutive refractions 2 weeks apart are stable. So that's the rule of twos. Now, here we are using the ASRS online calculators or the Barrett 2K. Also, you can use the intraoperative aberrometry. Remember, post-LASIK and post-RK are two different situations. You cannot interchange. Like, for example, Haig's L is only for post-LASIK. You cannot interchange. Also, remember to choose the correct form that you are filling, because by mistake, if you fill the wrong form, again, you will end up having a problem. Use of TK also is going to be very useful, especially in these cases, and it has been found to be very useful. Now let's look at another example, 41-year-old patient, 12 cut RK. Again, you can see topography. Ideally, you should do a topography for all these patients. Again, look at the EKR report, greater keratometric variability. Here it was a quite high myope and keratometry was not possible also on the autoref. Here you can see it's almost plus 7 diopters. On the ASRS online calculator, maximum was 7, whereas minimum was 4.8. So if you only go in with the average of 5.8, you might have a hyperopic surprise. So here we kept used the maximum value. So we used the 7.5 for technics. This was again the toric calculation that we did for this patient, and post-operatively patient did extremely well. So 6 by 9 unaided. So even torics in these patients do very well. Now, this was a patient now, 47-year-old, 4 cut RK. Okay, nuclear cataract came to you with -8 diopters of spherical refraction. Now, look at the topography. It's quite much better compared to the earlier ones. Spherical aberration and all are very good. Now, look at the EKR report here. It's quite good, and there's a very tall peak and very less of keratometric variability. Now, in such cases, this patient was quite demanding and wanted more and more spectacle independence. So probably in such cases, we can go in for an advanced monofocal or an EDOF like a pure C, which will not have diffractive zones, will have less amount of glare and halos, and probably will give a better functional range of vision for the patient. Now, this was a patient 18 cut RK. Now, this was one of the flattest case I'd ever seen. 27, 28 was the keratometric reading. So again, on the ACRS calculator, you see here the average power was 26.7, and the maximum was 26.8, but we kept a target of 1.5, so we used a 28 diopter lens. So this was the surgery, and you can see the number of cuts. It was absolutely, there was no place to take a incision at all. Now, ideally in such cases, you should ideally take a sclerocorneal incision or at least a 2.2 millimeters. But when we went ahead with a corneal incision, look at what happened. These incisions easily open up, both as well as in the main incision as well as on the side port. You need to be very careful. Take a scleral incision in these patients. Thankfully, the patient did very well. So in this, even in spite of keeping a target of 1.5, you can see how the post-op refraction was quite good. Now my last case, very difficult and challenging case, 49-year-old male, one-eyed patient. Other eye, this eye was lost due to RD. And now in the only seeing eye where he had come to us for cataract, he had undergone both LASIK as well as RK. So you can see the RK cuts, plus you can see the interface, those metallic deposits that you can see here with the cataract. Now the challenge was, this was the corneal topography. Spherical aberration was as high as 2.3. This was the highest keratometric variability here. And this was the IOL master reading. Now the challenge here was, he has undergone both RK as well as LASIK. Now, if you look at this prior LASIK and prior RK, in the prior RK mode, it was showing a 21 diopter thickness, and in the post LASIK mode, it was showing a 23 diopters on Barrett-Rucke, and Hegel was 27. Now we put it on the ASRS online calculator, and you can see with the LASIK, it was showing around average of 24, maximum of 26, and with RK, it was showing 20.8 with an average maximum of 21. Now, which eye will power to choose? And we didn't have the other eye for comparison. Finally, we went ahead with a 25 diopters lens. Now, this was the OCT cornea. You can see those metallic deposits in the interface. Patient wanted a flax procedure, so we went ahead and did a flax also. Here now we did a scleral incision because we didn't want the incisions to open up. This was a one-eyed patient. Rest of the procedures was almost the same. We are removing the capsulotomy flap here. You have to be very careful because through RK cuts, when you're doing flax, you can have skip areas, and it's a postage stamp perforation. So you need to be very careful to complete the capsulotomy here. Rest of the procedure was fairly the same. We used Technis single monofocal lens. Why is it not going ahead? Oh, 1 minute, it's showing closer program. So basically, this was the last case, and this was how we did. And post-operatively, patient did actually very well. I think it has just stopped. 1 minute. Let me just share the last. Minute. Yeah, I think it's fine because that was the last case only. So basically, we had very good outcomes, and
Okay, ma'am.
these were the cases that I had to share. Thank you very much for your kind attention. Okay.
Thanks a lot, ma'am, for a wonderful, wonderful talk. And ma'am, during your chair time with the patient, what are the things that you actually want to tell the patient, especially in patients where you have a lot of RK cuts, maybe let's say 12 to 14. So what are your chair time specifics that you would like to talk to the patient?
Yeah. Yes, so first of all, I tell the patient that he has already undergone a corneal procedure first. So it's not a normal cataract. So even if we do the cataract surgery as best as we cannot, as achieve or expect 100% good outcome. So there could be some residual refractive error. And even if there is no residual refractive error, there could be slight drop in contrast sensitivity or night vision issues like glare and halos. So he cannot compare himself to a normal patient. He has to be mentally ready to accept that, and definitely ready to accept a little number for distance as well as for near. And depending on the number of cuts, depending on the corneal topography, I actually show him and then tell him how different it is from a normal cornea. And we do repeat readings and do a topography, repeat readings and see whether it's consistent or not. Yeah.
So counseling in RK is not a backup plan, it's a primary intervention. So counseling is part of the surgery which cannot be avoided. Whether we remember or not, cornea is going to remember the RK marks, and interestingly, it behaves in its own way in different day of time, and different time of day, it can have diurnal variation also. So we have to be careful dealing with all these cases. And interesting part of RK is that when you look at the astigmatism on any of keratometers, the keratometers average out astigmatism. So it does not tell you the true picture of how the astigmatism is. Uh, it may uh, it may tell you the geometric part of the astigmatism. Unfortunately, in RK, astigmatism can be geographic also. It can be in any shape or something. Trying to treat those kind of geographic astigmatism with the geometry does not always work, right? So that's why when Dr. Anaga said that select your case for toric when you want to select with a regular astigmatism and not every case.
And which kind of sutures do you all prefer? Dr. Arvind, sir, would you like to comment on this? Suturing in post-RK cases?
Yes, suturing is a must because the wound integrity, and we'll look at the commensal. So we need to prevent the endophthalmitis also. So yes, of course, one suture always I prefer in all post-RK cases.
Do we have any other questions from anyone over here?
Can I have a question? Dr. Himanshu,
Yes, sir.
I wanted to ask your thoughts on a patient who has come to you with both LASIK and RK done. How would you approach such a case?
I mean, today only I just had one patient with 35 RK cuts. I don't know, 3 times he has been cut, and 35 RK cuts, and there are 3 arcuate cuts in that. I mean,
35.
35. 3 times he has been taken in surgery as a kid. I mean, he was operated, and his brother also I operated, and he got. And on top of that, he
LASIK.
has undergone a PRK. So surface is altered. So whatever the interesting part here is that whatever we do, whichever instrument we take to measure, every instrument has error, and every instrument, whatever they are doing, we may be able to measure the repeatability of the instrument, but we cannot measure the accuracy of instrument, because what we are measuring is a corneal power, entire power, which is so different in different zone. But our machine gives one number to it. And any IL formula which we take, it finally averages down to K value as one number. Irrespective, whatever you take, it averages, and then it takes the average K, and then it utilizes average K in the calculation. So imagine that how much of variability and error we are dealing with things. So there is absolutely no way anybody can beat their chest and say, in my hand, I never had any surprises. Of course, it does not happen. And that means you either were not following a case long enough, because as Dr. Anaga said, even at long term, there is chances of regression. So the interesting part, and as you rightly pointed out, in RK, the relationship between anterior and posterior surface of the cornea is still maintained. But in LASIK, laser has destroyed the relationship between anterior and posterior. So we are dealing with cornea which is irregular, and on top of that, we are dealing with cornea which has an irregular relationship. It's certainly not the best case in anybody's hand. So anybody showing bravado that in my hand I can handle all such kind of thing, I think we have to take it with pinch of salt. And what you did was an amazing job, and I think we all should remember that things can actually go wrong, and we should have a backup plan with us.
So with that, I'd like to move on and invite Dr. Himanshu to talk. And he is.
We can't hear you, Aishwarya.
Can you hear me now?
Yes, yes.
Yes, sir. So Dr. Himanshu Mataria, sir, is currently working as.
You are inaudible.
Hello? Can you hear me now?
Yeah, now.
Yes.
When you're turning on the other side, we can't hear you.
Oh, okay.
Okay. You don't need to introduce me if you want to.
Okay.
You can just call me. That's fine.
Okay, sir. But sir is actually right now the head of department and senior consultant in the Department of Cornea and Refractive Surgery and Ocular Surface at Narayan Nethralaya, Banaghatta Road, Bangalore. And he's published around more than 50 scientific papers in various national and international journals. And now we would like to request sir to please speak on his topic, which is phaco and post-keratoplasty cases. Over to you, sir.
Thank you, Aishwarya. Thank you, Harshul, for having me here. Am I audible and my slides are visible?
Yes, sir.
Okay, perfect, great. I do not have any financial disclosure here. My topic today is post-keratoplasty cataract. Now, remember one thing, post-keratoplasty cataract, when we talk about keratoplasty cataract is inevitable. Post-keratoplasty, at one point of time, if you live long enough, there will be cataract. In fact, earlier than later, because of topical steroid usage, because of primary pathology, and many other things, your cataract is going to be much earlier than you would have expected in a normal individual. However, having said that, cataract in a post-keratoplasty eyes can actually be considered as a blessing in disguise because it's one of the best method for the visual rehabilitation. Remember, when we do a corneal transplant, the spherical outcome cannot be predicted in whatever best of the hands. So there can be very high risk. Even if I do the best suturing and zero astigmatism, still I cannot predict the spherical outcome. And it also depends on the axial length of the patient and many things. Hence, when we develop cataract, this is the time where we can actually correct that spherical surprise also. On top of that, if the astigmatism is able to be dealt with toric lens, well, we have a chance to correct the astigmatism also. So I consider this as a blessing in disguise. When do we do the cataract surgery? Well, in these cases, earlier the better. Before the cataract becomes too hard and before we have to use too much energy, which damages the endothelium. Having said that, we always need to wait for graft-host junction to heal. Now, how do we know? Well, interestingly, what we have to look at it between two sutures, that hump, what we see, what you can see in the picture, till you have that kind of bulging or hump between two sutures, that means graft-host junction is not healed. And when you see that becoming flat, it means it is healed. You can very well visualize this thing on an anterior segment OCT, but you do not always need an instrument like anterior segment OCT. I would prefer, if I want to put a toric lens, or if I want to take care of the astigmatism, or even if I am I want to take care of the spherical outcome appropriately, I would wait for all the sutures to be out, and then only I'll plan my surgery. But unnecessarily delay would not help you. How do we work up? Well, we have to take the vision acuity, we have to do the refraction, a good slit lamp examination, and abrometry and topography along with the specular microscopy completes the workup. Having said that, if you do not have abrometry and those things, it's absolutely fine. But a topography and an endothelial count measurement is something which I would surely say is must. When we talk about effect of cataract surgery on endothelium, before that, we should understand that if a full thickness graft we have done, by default, with the time, the endothelial cells keep dying. And we know that the survival of the graft at long term becomes little difficult because the endothelial cell count keep dropping down. On top of that, the cataract surgery per se reduces the endothelial cell, and as you can see here in post-PK, drop can be as high as 44%. So person with a low endothelial count, person with a long-standing graft, person with PKP compared to DALK would have a high risk of endothelial dysfunction or endothelial decompensation. Coming to the surgical precautions, surgical precaution wise, when we look at, I'll show you a video for better visualization. Is the sound audible? Minimize the unnecessary installation of the eye drops.
Yeah, audible.
Yes, sir.
Thank you. Periorbital anesthesia for manipulation of the globe to improve viewing. Higher-end microscope, dispersive viscoelastic over the epithelium, and to use endoilluminator to see what is not seen under the normal microscope light. During incisions, avoid injury to the graft-host junction. Incision could be clear corneal, useful for small to medium-sized graft, but has a tendency to leak and risk to the endothelium. However, scleral tunnel incision may be useful for the large graft and less likely to leak. But the glaucoma surgery could be difficult following these. Endothelial protection can be achieved by Arshinov's soft shell technique of injection of dispersive OVD followed by cohesive OVD. The cohesive OVD pushes the dispersive OVD onto the endothelium, protecting it. Use of irrigating solution like BSS Plus can further add to its protection. In management of the capsule, one can use trypan blue for better visualization. Use micro-rhexis forceps and aim for a smaller rhexis to prevent popping out of the IOL from the bag to avoid endothelial damage. Phaco emulsification should be done with low phaco power and high vacuum. Aim for in-the-bag phaco emulsification and avoid chatter. Intraocular lens should preferably be hydrophobic acrylic. In case of regular astigmatism, a toric IOL can be planned, and for the cases with high astigmatism, customized toric IOL can be planned. Wound closure is mandatory to prevent the wound leak and control the unpredictable surgical induced astigmatism. So when we talk about now intraocular lens, can we put a toric lens post PKP astigmatism? Well, it depends on what kind of astigmatism you are dealing with. If you're dealing with a case where all sutures are out, astigmatism is regular, and in case of graft decompensation or failure, you are able to do a DSEC or DMEC, then of course go ahead and you can do a toric IOL. But if the astigmatism is irregular and all sutures are not out, it was a total cataract and you're dealing with a total cataract, and that's the reason you're going ahead with the surgery earlier, then a toric lens may not be advisable. If you look at the left side lens, which has the regular astigmatism, well, the toric lens may help you. But on the right side, what you're seeing here, there is a significant asymmetry there, and the toric lens may not be the best case scenario there. When we are looking at, Anaga spoke about, in fact, Vardhan and Anaga both spoke about the EKR maps. So try to take the zonal reading and average of that. But ultimately, remember, if the K values are irregular, there are chances of surprise. The lens, whichever lens and whichever formula works on hand is fine. It's not nothing special, but usually we do use now the universal K formula. In case of a very high astigmatism, a customized toric lens works wonderfully well, and to my surprise, we can actually handle quite significant amount of astigmatism in there. My journey started with a case of post-keratoplastic cataract. The right eye had already undergone cataract surgery with poor visual outcome. The left eye presented with a mature cataract and a clear graft with an astigmatism of 16.5 diopter. The dilemma was what to do. The options were A. Limbal relaxing incisions, but it won't correct 16 diopter. B. Surface ablation, which would also not correct much. C. V-grafting. For a clear graft? Seriously? Finally, it hit me. The best option would be a toric IOL. Challenges in this case were very high astigmatism. Where would we find such a lens? Post PKP low endothelial count. What fails? What if the toric IOL rotates? For rotation of more than 15 degrees, there would be total loss of quality of the image. The answer is custom toric IOL. The procedure included pre-op horizontal axis marking done on slit lamp with an undilated pupil.
Intraoperatively, IOL axis was marked. Care was taken to avoid any injury to the graft using the soft shell technique. Adequate size capsular axis was performed. Following careful phaco emulsification, toric IOL was inserted and rotated to the final axis. The customized IOL implanted had 20 diopter cylindrical power. The vision outcome was excellent. There was no damage to the endothelium, and the quality of vision measured on the abrometry showed remarkable improvement. But the question was, what did it mean to the patient? Let's see. On opening the patch on day 1, the patient was thrilled about his newfound vision. This, to me, was the real success.
So what do we learn from here? Post-PKP cataract is a special scenario. Take care of endothelium. Toric IOL can be considered in case of a regular, stable astigmatism and all sutures are out. And for the high astigmatism, custom toric lens can be considered. Thank you very much.
Thank you so much for a very enlightening talk, sir. Dr. Arvind, sir, would you like to ask a few questions here?
Yeah. So just discussion on the Rho kinase inhibitor role in the low ACD. So I've gone through few studies by Professor Hisataka Fujimoto. So they used this 0.4% ripasudil, and they compared with the control group. Although the sample size was not much, it was 14 only. So the reduction in the ECD in the ripasudil group was 125 mean, whereas in the control group, it was 300 with a significant p-value difference. So what is your take, all the expert panelists and all the moderator?
That's a really nice thing, and we do use ripasudil when need arises. The interesting part of that is that we look at the therapeutic window of any medication or any medical treatment. If the risk involved is higher, then the benefit which we get, well, not the great idea. But if the side effect of the medicine is not that great and the benefit is higher, we surely can consider. And ripasudil lies into that. In some of them, if they can't tolerate, well, we do not have a choice. The interesting part of any of such kind of study is we have to understand when we look at the endothelial count is per millimeter square cells which we see. Now, it will only alter when the cells die and they are replaced by enlarging surrounding cell.
Polymegatism.
Yeah, it will ultimately reduce the number of cells in that per millimeter square. So ideally speaking, for any of these things, in any of these studies, unless they have studied for a longer period of time, it's very, very difficult for us to interpret based on just a specular count which they throw at us. But as you rightly said, it's certainly a great boon to us, and we can surely use in cases where it's needed.
And also we need to remove all the sutures, wait for some time, and then only go for the toric in the post-PK patient, my
100%,
experience.
100%. There's absolutely no doubt.
So nowadays, many patients choose EDOF lenses for post-PK eyes as well sometimes. So what is your take on that, sir?
Sure, you can do. I mean, basically, both patient as well as surgeon should understand what are you planning to achieve from that. Now, whether you use EDOF lens or whether you use monofocal lens, if your surface is irregular, if you have irregular astigmatism, it's not going to do anything great to the patient. Can it give you a better quality of vision than a good fitting hard contact lens? Of course not. So if patient is already wearing an RGP or a Rose-K or a scleral lens, whether you put anything like that, it's not going to do anything better than those hard contact lenses. So remember that if we feel that the surface is regular and if the EDOF is going to help them, sure, why not? But if you feel surface is not regular, just because EDOFs are called premium lens and patient feels that they've spent more money and they are happy, I don't think that works out.
In cases of these post RK and the post LASIK patient, we need an IOL, ideal IOL, that has this ability of the extended means we talk about the depth of focus. That is very important. What is depth of focus? It is a little bit different from the defocus curve. Depth of focus, even if our biometry is wrong, because we have this hyperopic shift in most of the patient. So it is the dioptric power from plus to minus. So in a teenager, it is between plus 2.0 diopter to minus 3.5. So if any IOL that has this much of depth of focus, the patient will be happy because the distant vision will be remain between the 6x6 and 6x6 part, even if the biometry goes wrong up to 5 diopter.
Please. Okay, sir. Thank you. Dr. Rohan?
Yeah, so there was one point I wanted to ask Dr. Manchu sir. Whenever I get a chance to pick his brain, I take it. So, sir, like you said that you just had a case of somebody who had 35 RK cuts. So, would you sort of counsel that patient not to go ahead for surgery for as long as possible?
Not exactly. I would rather be a little earlier in the surgery. I may not be very early where the cataract becomes too soft and difficult to handle, but certainly I do not want that cataract to become harder and.
But sorry, let me rephrase it. If the patient does not have a cataract,
Sure.
then and the patient wants more spectacle independence, or what can you do something for me interventionally? Then what's your take on it?
So, cataract surgery in any of these cases is not something which is extremely predictable, right? So, if I'm doing something where I can deliver a result which is very predictable, I surely would have low threshold and offer that surgery to somebody. But if I'm myself not sure about the predictability of my intervention, am I helping this patient? No. I think sometimes they may not uh, tell me, rather, I would say, like, I'm sure we all know that they remember LASIK surgeon's name, they remember all refractive surgeon's name, but even if we do a good job after that cataract surgery, we have forgotten until we commit some mistake and we have a residual. Now they will remember us that, oh, you residual power, I have to wear glasses. I mean, so we are there to take blame for all such kind of thing. Remember, the last surgeon takes all the blame. So if previous surgeon has butchered 30 cuts, it's still fine with them. If I am touching that eye, I'm taking all the blames and I'm going to handle that patient then onwards. So unnecessarily touching an eye where I cannot deliver as great outcome, I'd be very much wary about that.
So I would like to share my experience for such case. So we have an optical biometer with TK, the true keratometry, along with post LVC option in that. So once it was not working, so then we opted for the Shama's PL. So it has the modified K as well as the predicted ACD. And it went very well. So, but we use only in one case. So what is your experience with this formula, Himanshu sir?
So
Any experience?
I would say that the best part of all these things and worst part of all these cases are there are so many formulas which they so earlier I remember 20 years back I used to get reference for calculating formula and I would sit with all formulas, some 5-6 formula, and I'll compile and I'll give it to the primary surgeon that okay, friends, anybody. The interesting part is now with the ACRS calculator, something we are able to converge things and we are able to get something where there is something which we can possibly trust or at least have some guesstimate in between. The problem arises when there is no convergence. If the formulas are not coming together, if one formula goes one side, another formula gives another, that's the case where we are dealing with something where we have more potential of issues here. as Dr. Arvind was saying, that I would always target more myopia in these cases rather than having, because most of these cases have tendency of hyperopic outcome or hyperopic surprise rather than myopia. It's easier to treat myopia than to treat a residual hyperopia. So I would rather be on the myopic side in these cases. Whichever formula works in your hand, but please make sure that you have a backup plan in your hand, that if things do not work, how I'm going to handle that.
So thank you so much for all these insights. And now I think I can invite Dr. Rohan to invite Dr. Rushad Shroff. Please go ahead.
My absolute
Smiling at both
pleasure.
of them.
Absolute pleasure, dear friend, to invite Dr. Rushad Shroff, who's been my senior. I've learned so much from him. And just recently, we've been together for the last 4 days as well. And it's always lovely to hear his talks and see his surgical videos. So Dr. Rushad Shroff is currently working as the consultant and medical director of Shroff Eye Center, New Delhi. He completed his undergraduate MBBS training from Kasturba Medical College in Manipal, and he went on to complete his post-graduation and training from the Regional Institute of Ophthalmology in Trivandrum, and then subsequently did his fellowship in cataract and refractive cornea and optics from Narayan Nethralaya in Bangalore. He was facilitated with the Ophthalmic Hero of India award by the AIOS on multiple occasions, the 2017, 18, 2020, and 24. He has over 20 publications in international peer-reviewed journals and has an extremely great expression of interest in genes and corneal gene cone apex-derived focal weakening of keratoconus. He has reviewed articles in international journals and has been invited as guest editor for the International Journal of Biomed Research for the special issue for ocular immunology. And he is going to be talking to us on surgery, this Phaco emulsification surgery in keratoconic and ectatic eyes. Over to you, Dr. Rishad.
Thank you, Rohan, for that very, very kind introduction. And I learn as much from you as you've learned from me. I don't think we're very different from each other. And of course, with Himanshu sir sitting here, I think he's the guru of us all. So without further ado, let me just share my slides, and I'll be trying to shed some light on biometry in keratoconus, which is a topic that I like talking about. The slides are visible, right?
Yes, visible.
And you're audible.
Okay, great. So let's go through why IOL power calculation, why biometry is difficult in these cases. What are the assumptions in keratoconus and why keratoconus violates all these rules? When do we actually plan a cataract surgery for a keratoconus patient? And in this, it's actually the most important thing is choosing the right formula. And we'll go through a few case examples because keratoconus actually behaves like a continuum. It behaves differently if it's a mild keratoconus and differently if it's a severe keratoconus. My slides are not moving. 1 second. Yeah. So, like I said, morphology is the problem because a mild behaves very, very differently from an advanced keratoconus. And that's what we actually have to look at. Now, the challenge with the morphology of keratoconus is that it's an irregular astigmatism. That means that the corneal curvature, which normally is the same along a particular meridian, is not the same in keratoconus because of the cone at times being displaced from the center. Also, the visual axis in the steepest portion of the cornea generally may not align exactly. And the other thing we have to remember is that because of the way the surface is altered, the keratometry measurements become a little unrepeatable. And that's because the tear film can be unstable. There can be a decentered apex. If a patient is on contact lenses, especially on rigid lenses, there can be difficulty taking a contact lens holiday, and a contact lens warpage can occur because of that. Now, the other assumption on which biometry is based goes out of the window in keratoconus. So the corneal curvature, the ratio, the refractive index of 1.3375 tends to overestimate the IOL power in keratoconic eyes. The measurement errors are not uniform across the cornea, and these eyes also tend to have larger axial lengths and deeper anterior chambers. This leads to an issue in the estimation of the ELP. and the effective lens position becomes not as accurate. So overall, the whole issue in the biometry is an overestimation of the corneal power, which underestimates the IOL target power and results in hyperopia. Like we were discussing, in keratoconus, you have massive hyperopic surprises that can happen. Now, when do we actually go ahead and plan a surgery for a keratoconus patient? It's very important that the cataract should be visually significant, because these patients can have a lot of issues like glare and halos coming from the cornea, and we need to actually determine that the cataract is significant enough for us to operate. Generally, cataract, of course, develops after the age of 40 or later actually in life, and therefore most of the time the keratoconus tends to be stable when we are planning it. But that is an important thing to keep in mind, especially in a younger patient, that the keratoconus should be stable. Now, preoperative considerations, I've broken them into, what to do with the contact lenses, keratometry, choosing the right keratometry or which device to use it from, the right IOL power formulae, and actually which kind of IOL we should actually consider in keratoconic eyes. Now, in pre-op considerations for the contact lens holiday, contrary to popular beliefs, scleral lenses, because they tend to vault a little higher and not touch the cornea completely, you can actually reduce the amount of time for a scleral lens holiday to about 5 days. RGP lenses, it's advised in papers that it should be a 1 month holiday, but practically speaking, that's not very useful, because these patients are very dependent on their RGPs. So these are all recommended guidelines, but what we also have to understand in keratoconic patients is that the most important question to ask them before we do the cataract surgery is, are they happy with their contact lenses? If they're happy, if they're able to tolerate and wear the contact lens, then we can be more relaxed about these contact lens holiday guidelines. And then you would assume that the patient would also wear contact lenses after the surgery. Now, which case to use? Keratometry, there's a lot of debate about whether OCT is more accurate, say the IOL master with a swept source or a Scheimpflug based tomography. Like Dr. Himanshu rightly said, it's basically repeatability that we are looking at. There's no one way to get to an accurate keratometry in this. Now, this paper talked about a comparison between the IOL Master 700 and the Pentacam for keratometry values. And the final conclusion of this was that in general, the study indicated that IOL Master 700 measured a greater corneal curvature. So it gave you higher K values compared to the Pentacam AXL for those particular eyes with keratoconus. So that is a point to keep in mind. I'll come to that a little bit later, but just comparing between the two machines, the IOL Master 700 tended to give slightly more steep keratometry values. Now, choosing the right formula, of course, this is a very big conundrum that we get faced with in keratoconic eyes, and there are a huge number of formulas available online and traditionally. In the traditional formulas, even if you don't have access to the later formulas, the SRKT formula did very well, and that was because it used to give a myopic surprise most of the time, and that counteracts the hyperopia that you tend to get in keratoconus. So that actually tended to do well. Now, we have various different keratoconic formulas like the Barrett keratoconus formula and the Kane keratoconus formula, and they tend to do better in moderate and severe keratoconus grades. Of course, we also have to remember that there are certain keratometry values where you may not be able to input the data into any of these formulae, because they also have a cutoff level. And in that case, what we do, we'll come to a little bit later. This is just a slide depicting the Kane formula, and you can see this box over there. You can check that correctly, and then it will give you the keratoconic calculation. So this is an online formula which is available. It's started being available in some of the biometers also now, but it's very easy to input the data and get an analysis from this. Now, the important thing to remember about inputting data into the Kane formula is do not input total corneal values. So the IOL Master 700 will give you total keratometry. That's not what is to be inputted in the Kane keratoconus formula. Only input the anterior corneal values, because it already does analysis, and it kind of modifies the K value according to for the keratoconus part of the formula. So please remember, that's one point I want you to take home, that do not fill in total keratometry values into the Kane keratoconus formula. And the way it works is it minimizes the effect of the corneal power on the ELP prediction and therefore gives us a more accurate IOL power calculation. Now, Kane also has recommendations based on the mean keratometry values. So according to that, the recommendation is to target various different amounts of myopia, as I've mentioned here. So for eyes with severe keratoconus, when you're looking at something above 55, 56, I would tend to target about -2 diopters of residual myopia, because of even with the Kane formula, you may end up a little hyperopic, and it's always better, like we discussed, to stay myopic in these eyes. This is the Barrett True K calculator. And again, over here, it's based on the double K method, which means the measured K is used to calculate the IOL power, the theoretical K to predict the ELP. And it's got this keratoconus drop down you can select that mode, and that gives you the best result in keratoconic eyes. Now, this was a paper in ASCRS that compared various different formulas, and it broke it up into severe and non-severe keratoconus. One caveat to remember from this is they actually took severe keratoconus as the eyes with keratometry greater than 50 diopters in any one meridian. So that's not exactly following the Amsler-Krumik grading. Non-severe was anything less than that. So the non-severe actually pretty much became like normal eyes, whereas the severe keratoconus was anything that had significant amount of keratoconus. And you can see that in that, the Barrett Universal 2 with the keratoconus modification with PCA, M stands for measured posterior corneal astigmatism, that tended to do the best, along with the Barrett Universal keratoconus formula with the predicted PCA and the Kane keratoconus formula. Now, coming to the IOL to actually choose. Now, in general, the cornea has positive spherical aberration, and therefore most of our lenses have a negative spherical aberration. However, in keratoconus, the spherical aberration tends to be negative in the cornea, and it's worsened by the negative SA in the IOL itself. So it's better to try and use lenses that do not have negative spherical aberrations. No financial disclosure, but you have zero aberration lenses like the Boschenholm Envista and the Sensar series. Those may be a little bit better. Again, there's a lot that is stressed upon spherical aberration, but the cornea is highly aberrated anyway, so you're not going to make a massive difference by doing this. But if you were to look at the theoretical benefit, yes, you should avoid a negative spherical aberration based IOL. Now, toric IOLs, whether to consider or not, you have to advise and counsel the patient that this is basically an astigmatic debulking procedure. And like I mentioned earlier, the most important question to ask is whether this patient is likely to use contact lenses or not. If they are like contact lenses, please avoid using a toric IOL. You do not want to change the axis of the astigmatism and make the contact lens fitting more difficult. So that's the first question to ask. If a patient is not contact lens tolerant, then we can think about counseling towards a toric IOL in these cases. It's important while calculating the IOL power to, a couple of intraoperative points to keep in mind. There are some papers that talk about the risk of progression reduces by limbal or scleral tunnel incision. Practically speaking, we've done a fair number of eyes of keratoconus, even with clear corneal incisions. It doesn't make much of a difference. And like I mentioned, avoid toric IOLs in patients happy with scleral contact lenses or RGPs. Always counsel regarding the possibility of requiring either piggyback IOL or something like that, so that you prepare the patient as this is my backup plan in case of a very large surprise. And of course, contact lenses are our ally. So if they are happy with one, then you don't have to worry about that. Pinhole lenses have also been used abroad. These are not available in India. This is the IC8 AcuFocus. You can see it's got a pinhole aperture, and that increases the depth of focus. It reduces the aberrations from the peripheral cornea, and it tends to help in these highly aberrated corneas. And even in a post-RK patient, it can be considered. Multifocal IOLs are a definite no-no in these patients, because anyway the cornea is highly aberrated. By having a diffractive platform, you're going to probably get much more difficulty than it's worth. Now, I'll come to a few case examples just to illustrate what we do in different scenarios in cases of keratoconus and cataract. This was a 48-year-old lady. It was a left eye which had significant cataract where the vision had dropped. And if we look at the pentacam, it's not a very advanced keratoconus. It's a mild to moderate. You can see that the K2 is about 49, Kmax about 52.3 in this particular patient. Now, this lady had never worn contact lenses, so she was very, very keen on having a toric IOL. And at that point in time, we weren't really using any of the keratoconus formulas. So you can see here that even with the Barrett TrueK Universe, the total keratometry universal formula, the SRKT, all are reasonably similar. They're not too divergent in what they're giving in terms of the values. Now, we also, in cases where we are looking at a toric IOL, I do look at the EKR map on the pentacam or on the topography. That just tells us whether the axis of astigmatism is regular across the pupillary area. So you see the dotted lines, that's the mesopic pupil size. And that's where we want to make sure that the axis of astigmatism and the magnitude is reasonably okay. And therefore, in those cases, like you can see here, it's fairly regular. It's staying between about 60 and 66 degrees up to the 4.5 mm pupil. And those are the cases where you're good to have a toric IOL actually implanted. Now, we did retrospectively go back and look at the Kane formula, and you can see here again, it's showing about 14.5 diopters as the intended target. So showing that basically in a mild keratoconus, even your traditional formulas would tend to do well. So there's nothing to get worried about in those particular eyes. So we went ahead with a T9 in this patient. Post-operatively, there was still a little bit of residual cylinder, but she did well and overall was pretty happy with the outcome. This is another patient where the Kmax was about 62. So this is a slightly more advanced keratoconus. The other eye had even more severe keratoconus, and that I'm going to come to shortly. But you can see this is a fairly advanced cone, and this patient had significant cataract, and we had to plan it. Now, like I mentioned earlier, you can have unrepeatable measurements at times. So you can have keratometry, which is higher on taking a measurement once and lower when you take the measurement a second time. As you can see here, the K1 is 57.58 in the first reading and compared to 53 in the second. Always better to use the ones which have lower K values. This counteracts the hyperopia that you're likely to get. So another very key take home in keratoconus or wherever you're likely to get hyperopic surprises is to use the lower K values that you're getting. Now this, we did the calculation with Kane with a target of -2, and you can see it was showing a +4 diopter lens. We did it with the pentacam. So it's always good to take readings from different machines and then compare what's actually happening. So with the pentacam with the Kane target of -2, you're getting about 4.5. So fairly similar again. This is the Barrett keratoconus with the predicted posterior corneal astigmatism showing a power of about 2.5. And this is how you input the data into the keratoconus mode. You can input data from either the IOL master or by going on the machine and taking the posterior corneal values, or from the pentacam, you can also input it. So it tells you which machine you're using in the Barrett TrueK formula. You can see here, this is from the pentacam keratoconus values that I've taken. And again, it's showing a +3 diopter lens to be implanted. With the predicted PCA with the IOL master, again, fairly similar, 2.5. And with the measured PCA on the IOL master, again, about 3. So what I'm trying to tell you is that the IOL master and the pentacam showed reasonably good matching in terms of the outcomes that we were getting with this. So we went ahead with the +4. Now, this is the other eye of the same patient, and here the keratometry is even more advanced. You can see that it's a very, very steep cornea. The Kmax is about 77. Now, in this particular eye, we were unable to input the data in either the Kane keratoconus formula or the Barrett TrueK keratoconus formula because it's outside the range. Barrett takes up to 60 and Kane takes up to 65. So with this in mind, one of the things to do, one of the strategies in very advanced keratoconus, if you don't have an option and have to operate the cataract and you're not doing a DALC procedure for this patient later on, then you use standard keratometry. So standard case is 43.25 and you can get an IOL power of about 13 in this particular case with that. What the standard keratometry does is it tends to target more of a myopic outcome, and that is what we ended up with in this patient. So we went ahead with a +4 in the right eye and a +13 in the left. The right eye was pretty close to bang on. The left eye, of course, had a myopic surprise, but the patient was okay with wearing a lens as well. So overall, he was pretty happy with that outcome. These are our 13 eyes that we've done, and we've managed to get to a reasonable amount of accuracy. Obviously, not as good as you would get in normal eyes, but about 54% of our 13 eyes were within a half a diopter of the intended target, and about 70% within a diopter. And in terms of the astigmatic accuracy, again, about 46% were within half a diopter and 69% within a diopter of the intended target. So to summarize, standard approaches lead to hyperopia. It's always better to target myopia in these patients. A biometry machine or any machine that has rapid acquisition causes less variability from the tear film, and that's important to have in a keratoconus patient. Compare with multiple keratometry measurements, choose the lowest measured keratometry. For mild keratoconus, any formula does. For the more severe keratoconus, try to use the keratoconus formulas like Barrett True K keratoconus, Barrett Universal keratoconus, or the Kane keratoconus formula. For values which are very high keratometry values, use standard keratometry. It's important to target myopia because one is regarding the hyperopic surprise, the other is it's more useful unaided vision. So most of our tasks are near these days. It's easier to insert and fit a contact lens if you've left the patient a little myopic. So it's easier for them to actually handle the contact lens, which is what they're more dependent on in keratoconus. Under promise and over deliver. And remember, the most important question is contact lenses. Is the patient happy with them or not? Contact lenses are our main ally in a keratoconic eye. So thank you so much for a patient listening. And with that, I'd be happy to take any questions.
Thank you, Dr. Rashad. That was very enlightening. And now I would like to go to one of the questions which has come from one of the attendees, that which formula to look at when the keratoconus patient has undergone TCAT before and has come for cataract. So what would be your take on that? Which formula to look at when keratoconus patient has undergone TCAT before and has come for cataract?
Has undergone a TCAT before?
Yes.
So it would still be the same thing, because you are going to modify your keratometry in any of these procedures. It finally comes down to what is the measured keratometry. So in those cases also, I would astigmatism, and which actually measure the anterior and the posterior K values. And then based on that, I think you can go ahead with either Barrett True K keratoconus with the measured PCA, or even the Kane formula. So it would come down to what is measuring the Ks accurately in a post-TCAT eye. The other thing to be a little concerned about is there some amount of haze? So if there's haze and the pentacam is not picking up the reading because of backscatter from the haze, then I would look at something which is more OCT dependent. Even your OCTs like TOMI or like MS39, etc., have they can give you better accuracy on the K values in certain cases like that. So it's important to actually go into the detail of the image, see how your haze or densitometry also is. And if that is impacting it, then I would go with something that doesn't get as impacted by that.
So in terms of the customized IOLs, what has been your experience regarding the Zeiss IOLs versus the Care Group IOLs? Would you like to comment on that?
The custom toric IOLs.
Yes, custom toric IOLs, especially for keratoconus eyes, for the severe keratoconus eyes.
I have used only the Care Group ones, so I don't really have experience with the Zeiss ones as far as the custom toric goes. But I do know that the custom toric works very well from the Care Group one, and I would assume the Zeiss one works pretty similarly. The good thing about it is they can create it in pretty high dioptric values. So
Yeah.
I think the patient I had implanted in was about 12 diopters of corneal astigmatism, and they did pretty well with that IOL. So overall, I think they do quite well, as long as, again, you are asking the patient about even a custom toric or any IOL cannot do as well as a contact lens. A well-fit contact lens will not work None of the IOLs can do that. So that is the first and most essential thing to determine. But they do well for patients who are not contact lens tolerant.
Himanshu sir, would you like to tell us more about the piggyback IOLs in such cases of keratoconus?
So not just keratoconus, but any of these refractive surprises, piggyback IOL can be in one option, and especially in that piggyback option, we are talking about using a phakic IOL as piggyback IOL, and it works pretty decently well. But again, it boils down to same thing what Rushad stressed upon, that if patient is able to use a contact lens for that refractive surprise, trust me, that vision quality would be far better than you trying to put anything else. You, as such, there is significant irregularity of the cornea. Cornea is irregular. You are inserting one more optical device. It makes you happy by reducing the spherical equivalent, but the quality of vision wise, nothing can beat a good fitting hard contact lens.
Okay. I think we are just about to end in 3 minutes. I would like to request Mr. Sunil to put up the question as over here, the MCQ questions. Mr. Sunil?
Already done, ma'am.
Okay. So everyone, can you please just fill up the MCQs over here and go ahead with that?
May I ask one question?
Sure, sir. Please go ahead, please, sir.
What is the possible role of a light adjustable lens in the future, although they are not available right now in India, in cases of stable keratoconus and with regular astigmatism? I feel that that would have been a great choice in future.
Yes, sir. That is one of the choices that they're looking at in the US, and I think there are some, at least some presentations that I saw on it, that it is quite useful in I would say mild and moderate keratoconus, where you can get a reasonable value to that. Also, it should be, like you mentioned, a stable keratoconus. But the IC8, the pinhole aperture lens, is something that more people have used and have been quite happy with. It works kind of like the pinhole pupilloplasty that Amar sir and all do for highly aberrated corneas.
Also have a control over the aberration part.
It does, and you have that peripheral skirt where you can see the retina through as well. So overall, that design makes it a little more appealing where it's available.
Thank you. So thank you, Aishwarya. Thank you, Dr. Harshul. Thank you, all the speakers.
Everybody, thank you.
And the panelists. Thank you so very much.
Thank you. Thank you.
Okay.
One question in the chat box. Unable to see MCQs. Aishwarya?
Yes, sir. Mr. Sunil, can you just look at that, please?
Yeah, I'll just check, ma'am. In case it is not available for current module, it will be posted in next 5-10 minutes. But the link will be the same.
Okay. So anyone else who would like to ask any particular questions over here, please go ahead. In the webinar chat, you can chat over here. You can please post your questions. So, Dr. Arvind sir, which has been your most difficult case when it comes to post-refractive phaco cases? Would you like to tell us more about that?
Yes, that was a case. And so with 11, this diopter of astigmatism, so I opted for the JAIS. So it works well between JAIS and CARE. Both works well. But the problem with JAIS is that it takes 3 months to come to India. And CARE group, they provide between 3 week to 4 week time. So that is the advantage with the CARE group.
Okay.
Also means the patient with post-refractive, they are coming with dry eye problems also. So then we are facing a lot of challenges doing the biometry. So just put these lubricating eye drop and it works well. In cases of hard cataract, so it's again difficult. So when we are dilating the pupil, so 95% of the time we are able to get the IL power. So these are my take. In cases of applanation, so I observed that what the residents are doing, a very particular mistake, they are holding it like a pen. So that puts pressure over the cornea and different readings come. So we need to hold it like a rifle, like this. It doesn't exert any pressure at all over the cornea. So these are my practical tips, what the residents, they are committing the mistake, the common mistakes.
Also, I think like how Dr. Rushad mentioned that I think we need to have a mindset change regarding the formula that we are using. A cane keratoconus formula has to be regularly used. It's very simple and it has a very good take amongst like, in mild to moderate to severe keratoconus cases. And like he mentioned, I think on a regular basis, wherever you feel that, you are exceeding 48 diopters K values over there, just put the values, just have a look, and probably like we have completely moved on to keratoconus values, cane formula for quite some time now, and we're getting very good results. So I think that is one mindset change which needs to come, even for Barrett, keratoconus formula, which has to come. Like we have to move from SRKT formulas now.
We need to evolve there, Dr. Aishwarya, because change is the only constant.
Yeah.
So nothing to be feared of. So we need to opt for these two formula, Barrett True K, as well as this cane. So these our team is also doing a head-to-head trial. Until now, there is only a difference of half diopter spherical equivalent in both the formulas. So these are two great formulas in the keratoconic eyes. Yes, Dr. Rushad, you were saying something.
I think, sir, cane also works very well for hyperopic eyes. That's been shown in a few studies as well. That for extreme hyperopia, cane also does very, very well. Not the keratoconus modification, just the general cane formula as well does well for that.
The general one also, yeah, correct. Okay, I think our MCQs should be done by now. Please remember that people who are not able to see it, you also. Okay.
It's uploaded.
Okay,
It can be done later also, not necessarily now.
Okay, sir. So I think I thank you all. Thank you all for a wonderful, wonderful talk. Thank you, Dr. Arvind Kumar Mourya, sir. Thank you, Dr. Rushad, and thank you, Dr. Rohan, for all your time over here. Thank you, Dr. Himanshu and Dr. Harshul Tak, for giving us such an opportunity over here. Have a great day.